When we were planning this PTAC session, we wanted to prioritize hearing some from physicians that are actually practicing on the front lines, and that's why this group was actually selected. We really want to understand your real-life experiences with population health models and care coordination. I've asked our panelists to go ahead and turn the video on if you're not already on. It looks like you're already on. And what I'm going to do is I'm going to briefly introduce each panelist, but then I want you to introduce yourself. And if you have slides, I know that a few of you have slides to present, and if not, if you have a short discussion that you want to have, then go ahead and do that. The full biographies of our panelists are on the ASPE PTAC website, along with other materials for today's meeting. And after you all introduce yourself and share with the group whatever you have to share, we have some structured questions that we'll walk through. But then after a few questions, I'm going to open it up to the PTAC committee for questions to you and for discussion. So we'll start out with Dr. John Birkmeyer, who is President of Medical Group at Sound Physicians. Welcome, John. You want to make any statements or share anything?
Sure. Good morning, everybody. So my name is John Birkmeyer. I'm a general surgeon, a health services researcher by background, grew up with the Dartmouth Atlas, and I'm president of Sound Physicians. Sound Physicians is a large-scale medical group specializing in inpatient care, so EM, hospital medicine, critical care, and anesthesia. We employ a little over 5,000 docs and APPs, and we have practices in approximately 350 hospitals across the country. My part of the ecosystem tends to get painted with a broad brush, but we're generally viewed as one of the good guys. So we're physician founded and led. We're have never been in the surprise billing business. And, uniquely, we're one of the early adopters of the interface between hospital-based care and value-based payment models. We were an early entrant, and up until last year, we're probably the largest single episode initiator for the Medicare Bundle Payment Initiative. We have a very large long-term care ACO, and we have, and all of our national contracts with private payers are value-based. Just given the theme of this session, I'll close by, leaving you with a couple of thoughts, or at least a couple of recommendations about how to think about the role of specialists in alternative payment models. This is something that I and we have thought a lot about. And recommendation number one is, to rethink how we categorize physician specialties, as I've seen in, some of the agenda for this panel and otherwise, the dichotomization is primary care versus specialist. And I would tweak that a little bit to say that it's generalist versus specialist. Generalists consist obviously of groups like primary care providers, but they include a lot of folks working outside of ambulatory settings, such as EM docs and hospitalists. A generalist, of course, is somebody that treats patients across a full array of conditions and organ systems, but relative to this discussion, they are just like PCPs in that they influence not only quality, but total spending by serving as gatekeepers for downstream services rather than what they themselves do. The second and somewhat correlated recommendation is to design APM models, that reflect the most important levers for each type of specialty. So, for example, for emergency medicine docs, their biggest impact on healthcare spending is decisions about who gets admitted and who doesn't get admitted from the ED. So their most important role in the APM world is probably in payment models that at least pull them into a share of, the spending that attached to hospitalization rates, alongside the that are upstream of them. Hospitalists, and this is kind of largely what Sound Physicians does, influence total spending by what happens by not whether people get in the hospital, but what happens during and afterwards. So by far, the biggest impact of hospitalists is in decisions about where people go after discharge. So it's the use of facility-based post-acute care, it's readmissions, it's managing what happens for patients in SNFs, and it's basically managing end-of-life care and aligning intensive care with patients' values and their preferences. So it's not surprising that hospitalists best align with those types of spending, and probably with episode payment models rather than with population payments models. And finally, specialists are so heterogeneous as to be impossible to leave sort of a single recommendation, but at least most of them best align with population rather than episode-based spending models. And I think at least for procedurally oriented specialists, specialty-specific spend per capita or procedure rates per capita are probably the biggest segment of population spend that they should be considered for. So thank you everybody for the time.
John, that was great. I appreciate all that input. So next we have Dr. Nichola Davis, who is Vice President and Chief Population Health Officer at NYC Health and Hospitals. Nichola, do you want to make some statements? Introduce yourself.
Sure. Thank you. Good morning. Really, I'm excited to be here this morning, and I want to just thank you for the invitation to participate in such a timely and really important discussion. So I'm a general internist by training and an obesity medicine physician, and I lead population health at New York City Health and Hospitals. Just in a way of a bit of background, New York City Health and Hospitals is the largest municipal healthcare system in the country. We deliver high-quality healthcare services to all, regardless of their ability to pay, regardless of insurance status, regardless of income or immigration status. We serve over 1 million New Yorkers, and these are some of our most vulnerable New Yorkers each year at 70 locations throughout all of our 5 boroughs. And most of our patients are insured by Medicaid or they may be uninsured. So our system includes 11 hospitals, 5 post-acute and long-term care facilities. We have a large network of federally qualified health centers as well as home care services and an accountable care organization as well as a health plan. So across our health system, we have over about 700,000 primary care visits and a disproportionate amount of specialty visits with about 2 million specialty visits each year. Several years ago, I'd say about 5 years ago, we went to a single electronic medical record across our entire system, and that has been really critical in helping our specialty and our primary care providers to really coordinate the care of the patient. Just being able to see what each provider is doing has been really important. So I'd like to just highlight a couple of things that we've been doing in terms of just how we are integrating specialists in primary care. And one of the things that we've really worked on is building out e-consults. And for us, e-consults are asynchronous, and they're within our system. So they're within providers within our integrated system. And it really has been helpful in several ways. One is that for specialists, we can get the right patient to the right specialist. And so specialists can review the chart before for a patient that's been referred to them, for example. And then the specialist can determine whether or not they actually have to see the patient or whether they can just provide a consultation without the patient having to come in to see them. And they could provide that consultation and recommendation to the primary care provider, which is really helpful. And in a system like ours where we have challenges with just access, it's really helpful for e-consults to be able to triage those visits and to determine how urgent a visit might be, as well as to really think about whether or not the specialist has all of the information that they need. So a specialist might refer back to the primary care provider and recommend certain labs or testing be done prior to that visit, so that that specialty consultation is really a good consultation with all of the information at that time. There definitely has been the challenges with rolling out eConsult, which I'm happy to get into a little bit later in our conversation. But some of those challenges are really just getting providers on board, both the primary care providers as well as specialty providers on board and comfortable with getting away from that culture of patients having to be seen by the specialist. Another thing that we've really worked on is integrating our behavioral health into primary care, and we've done that through the collaborative care model over the years. That has really been helpful in managing our patients with depression and anxiety, and we're now thinking about expanding that model to include adolescents with ADHD in particular. And in that model, our psychiatrists, we have consulting psychiatrists that support our primary care providers, and within this collaborative care model, where there are collaborative care clinicians who are primarily social workers and nurses that will see the patients directly, and then they will have case reviews with a collaborative care psychiatrist, and that psychiatrist will make recommendations either to the primary care provider or to the collaborative care clinicians. And so that is a model that we've also had for about 7 years now, and we've expanded that throughout our system. And as I mentioned, we also have an ACO, which has about 7,500 attributed lives. And that ACO is a shared savings model. And one of the things that I'd like to highlight there is, because of the patient population that we take care of, we really have to focus on how we manage the social needs of our patients. And through models like the ACO, where there's shared savings, those savings can be put back into the primary care practice. And we've been fortunate to really meet the benchmarks each year. So we have been able to participate and receive shared savings that have gone back into the practice to really inform our model of care and be able to hire other support staff where there may not be a reimbursement model for example, patient navigators and community health workers, things like that, where there really isn't a clear reimbursement model for at this time. And those roles are really important in working together as a team to help our patients to achieve optimal care outcomes. So I'm really happy to be here to get into some of this discussion today, and I look forward to the conversation.
Thank you, Nicole. It's very interesting. I'm looking forward to digging into that a little bit deeper. So next we have Dr. Carol Greenlee, endocrinologist and owner of Western Slope Endocrinology. Carol?
Thank you. I'm happy to be here, and I also want to thank you for the hard work that this committee is doing. It's amazing. I am an endocrinologist in Western Colorado, but probably most relevant to the PTAC in this panel is my work on the patient-centered medical neighborhood. Within the American College of Physicians, I served as chair for several of the medical neighborhood-related work groups and subsequent policy papers and toolkits. And within the CMS-CMMI Transforming Clinical Practice Initiative, I served as faculty, helping implement components of the medical neighborhood. I also implemented it in my own practice. The medical neighborhood is intended to reduce fragmented care. Fragmented care occurs when we practice in silos of care with poor communication between those silos. The American College of Physicians recognized that for the patient-centered medical home to truly impact the harms and costs of fragmented care, there needed to be better connections to specialty care. However, there were no established guidelines, no defined standards for how to improve those connections. So the ACP convened work groups made up of primary care clinicians, specialty care representatives from a wide range of medical professional societies, patient and family advocates, and quality improvement and subject matter experts. And these work groups utilize consensus along with any available evidence to determine what is needed for better primary and specialty care collaboration and care coordination. So the resultant patient-centered medical neighborhood is not itself a delivery model or a payment model. Instead, it's an approach to coordinating care, connecting care, care collaboration that can be used as a framework inside of any care delivery model or any payment model, including a population-based total cost of care model. Since a referral is usually the first step in a primary specialty care interface, the first work focused on what is needed for a high-value referral process. This includes the critical elements of a referral request and a referral response, critical processes such as pre-visit review, close the loop, and referral tracking. Next slide. The first work also clarified the definition of a specialty care medical neighbor and the relationship of that medical neighbor to the patient and to primary care. The patient is, in this model, it's actually the patient's medical neighborhood. So the patient is the center of care, primary care is the hub of care, and specialty care is an extension of care with the role in care determined by the needs of the patient and their condition. Next slide. Subsequent work looked at what is needed for ongoing care collaboration beyond that initial referral. This includes a playbook on specific roles in care and their associated care responsibilities and shared expectations. This diagram shows the spectrum or the continuum in care and the division and responsibilities between primary care, in blue, specialty care in dark blue, for a referred condition. Primary care maintains the hub of care for the patient's ongoing needs. As the roles move to the right, the responsibility for the referred condition increase for the specialist. And with a consuming illness, the specialty care team may take on most management issues for a limited period of time. Now, a patient may have more than one condition that needs assistance from specialty care. So, for example, a primary care clinician may use an e-consult to get telederm advice on how to handle a skin lesion. They may do shared care co-management with the oncologist on cancer survivorship. A rheumatologist may take on principal care co-management for the elements of care for lupus. And if they also have type 1 diabetes on a pump, an endocrinologist might do principal care co-management for the diabetes. These roles need to be fluid so that if a condition worsens or deteriorates, specialty care can take on more of the management. Next slide. But also if a condition improves or resolves, there needs to be a pathway back to primary care or to a lower involvement of specialty care more appropriate to the condition. Right now, a lot of patients get stuck in primary care, in specialty care management because there isn't an established mechanism for transitioning back. And the playbook that goes with our policy paper provides a pathway and shared expectations for a safe and patient-centered transition of care for a condition back from specialty care to primary care. Next slide. So these principles, processes, critical elements, shared expectations provide a way within any model to actually improve care coordination, collaboration, and cohesion where we're all working together instead of in isolated silos to care for the patient. And I look forward to further discussion. Thank you.
Thank you. Great information. So next we have Dr. Jackson Griggs, who's Chief Executive Officer at Waco Family Medicine. Jackson.
Well, thanks so much for the introduction, and I'm just so honored to be a member of the panel. I'm I think a small fish compared with some of the magnitude of some of these systems, but nevertheless delighted to be in conversation with you today. So we're in Waco, Texas. We're a 15-site FQHC. We've been 24 years as an FQHC. We've had a family medicine residency program for 53 years that evolved into an FQHC 24 years ago. And we have 61,600 patients, just shy of 250,000 visits. 73% of our patients fall below federal poverty level. And Texas has chosen to be a Medicaid non-expansion state. So it makes taking care of population challenging from a financial standpoint. We have 32% uninsured, and that's going to grow as soon as the public health emergency ends and we start unraveling the Medicaid extension that's been in place. So next slide. It's kind of a wild west for FQHCs in Texas and value-based arrangements. We are actually, this is compared with, again, some of the scale of other panelists, we're just very early in our process, but we've got, upside only shared savings plans with local ACO for a small commercially insured population, Medicaid health plan, Medicare Advantage, and then we're just entering into some downside risk shared savings plan with another Medicaid MCO, and then we've just joined that FQHC only ACO for Medicare shared savings plan for traditional Medicare. Next slide. But I think I was asked to speak on the panel because of some of the work that we've been doing for about the last decade in behavioral health integration. And this is born out of necessity because of the dearth of mental health specialists in our region, and including a near absence of psychiatrists who care for underinsured or publicly insured patients. We've become the de facto mental health safety net in our community. We have this 10-year motto, which still rings true, which is we remind each other that the cavalry isn't coming. There is no wave of psychiatrists that's coming, and we're going to have to take care of the population. So out of need, we have built accordingly with non-psychiatrist behavioral health experts and ancillary tools in primary care. And as we've only more recently begun to lean into value-based contracts, we can see how that early integration will dovetail in an important way. So real quickly, let me introduce those delivery transformation efforts in behavioral health. So first, we assume that behavioral health is intrinsic to primary care, and given the high prevalence of mental health conditions and social factors that impact health in our population, we've invited clinical social workers to become a part of the core primary care team, and like work in primary care and unique from traditional psychotherapy settings, we expect those clinical social workers to move efficiently and sometimes juggle multiple patients at once. Our social workers, they screen for common mental health conditions, aid in diagnosis, they collaboratively develop treatment plans, and are just in constant dialogue with PCPs throughout the day. Sometimes they'll see patients before, sometimes during, and sometimes after the primary care clinician, depending on the patient needs and the flow of the clinic. And by bringing social workers onto the primary care space, the inequities that were previously seen within referral-based mental health access really just dropped to zero. So the second little column there, an eye towards population access in the setting of scarcity, we emphasize returning to functioning, focused psychotherapy, psychopharmacology, and really only when needed, stepping up to more in-depth and resource-intensive psychotherapy. So we do offer a co-located counseling service for evidence-based treatments that build on to the work started in primary care. And then the third category, with a high burden of substance use disorder in our population, we're working to mainstream substance use disorder diagnosis and management into primary care. but complicated cases need specialized help. So we have a primary care addiction medicine expert, clinical social worker, operate a consultation clinic for challenging cases. So if we have a woman who's pregnant, who's has alcohol use disorder, she would be someone who would be seen in our consultation clinic. But the specialty clinic operates on the premise that once the patient is stabilized, treatment plan is established, and the patient stabilized, that patient then returns to the primary care team. So I think similar to what Dr. Greenlee was just describing. So this premise is the same premise that's used by our human behavior and mental health clinic, which is staffed by a clinical psychologist and family physician. Clinic takes the most challenging cases from the entire population of the center, and then rather than keeping a patient for 7 to 10 sessions, the team works to get accurate diagnosis, a good treatment plan, and then returns the patient back to the primary care clinician. And obviously, if the treatment plan fails, then the primary care clinician would return the patient back to the HVMH clinic. But stewardship really is kind of the key here. If we don't have models where scarce specialists are able to see the most challenging cases and once stabilized, then return back to primary care, then we're just not going to reach population mental health. So stepped care approach can contribute to health and reduce healthcare costs. Next slide. And so we have, this is just for instance, in this kind of stepped care model, our pediatric behaviors program, stepped care model. So for children who have suffered traumatic stress, which is really most of our children, executive function, behavior regulation is much more challenging. So externalizing behaviors, which get classified as ADHD or disruptive behavior disorders, conduct, ODD, require understanding by all who interface with the child. So that's front desk staff, nursing staff, et cetera, who all get the training in child-adult relationship attachment. And then we train clinicians more intensely in a model we developed and published on how to coach parents to empathetically care for their children, which has demonstrated noteworthy improvements in outcome. But when these preliminary interventions fail, then those children get referred to the parent-child interaction therapy, a 10 to 12 session therapist-guided program. So, but again, stepping up to more intensive care and then stepping down as we can. So just final comment about stepped care model in primary care. It does require some base level competency in primary care. So next slide. This meant for us, once we began to identify mental health conditions a decade ago with much more higher prevalence because we were integrating behavioral health, we realized that our primary care team members were not comfortable with psychopharmacology. So we built decision support. There was such avid uptake in that decision support that we were building that we began to share that decision support outside of our own institution, ultimately developed an app. This is working collaboratively between our faculty and Mass General Psychiatry Academy. And so, we now have, it's called the Waco Guide to Psychopharmacology Primary Care. Last report is outdated slide. We've got about 10,000 app downloads and nearing 100,000, website users. Just decision support to help primary care doctors use psychopharmacology in an evidence-based manner, and that has helped a great deal our clinicians. So that's the last thing I have. So thank you.
Great, thank you. That was great information. So next we have Art Jones, who is principal of Health Management Association.
Yes, hi. I am a board-certified internist and cardiologist. I work with a community group where I was in training on the west side of Chicago in an underserved area that led to starting a community health center on the west side back in 1984. There were no new access points. There were no FQHC lookalike, so we got paid $13.65 for 99213 and $5 for uninsured. Fortunately, the local hospital, which had the highest percentage of uninsured and Medicaid in the state, except for Cook County, didn't have a cardiologist. So they paid me $8.50 to read an EKG, which was the money that supported the health center, because it only took me a minute to read an EKG and 20 minutes to see a patient for 99213. So we realized that wasn't sustainable, and so we started with primary care cap in 1987, and over 5 years gradually assumed capitated responsibility as a single FQHC for primary care, specialty care, outpatient diagnostics, behavioral health, pharmacy, ER, both professional and facility, and took upside and eventually downside as a single FQHC for inpatient services. When Medicare went to managed care in 97, did it with the same national companies for Medicare Advantage, for Medicare, and also for commercial. And the strategy for this was to realize that I needed to recruit not just primary care providers at the FQHC, but primary care, but also specialists who are willing to serve serve as the primary care provider and decision maker for really complex patients. That in fact, most of our PCPs were comfortable doing a lot of what they were trained, but when it came to really complex patients, is that they often refer those patients off, often to multiple specialists who didn't communicate with each other and didn't lead to good outcomes, excuse me. So our strategy to manage total cost of care was to bring on specialists that were willing to serve those really complex patients as the primary care decision maker. I stayed there for 27 years. I left in 2011 to help create Medical Home Network, which is 13 FQHCs and 3 health systems on the west side, serving the Chicago community. We have 178,000 Medicaid beneficiaries. We are totally delegated for care management. We're NCQA certified for care management. All the care management is done by staff that are employed by the FQHCs. We progress from shared savings to shared risk to global risk. We've generated, after covering all of our costs, over $100 billion in the first 6 years in margin that went back to our medical homes. Last year, we started in the direct contracting program, and this year we are in ACO REACH supporting 51 FQHCs in 7 states, about 50,000 Medicare beneficiaries in that global risk contract. So I think the lessons kind of learned. So you see, actually, I got introduced as consultant to HMA. I should have got that changed. I'm the Chief Medical Officer for Medical Home Network, but I also serve as a consultant for HMA, where I try and spread the experience that we've had at Medical Home Network. I think kind of the lessons that we've learned over the years is that every patient needs a primary decision maker. And sometimes that's a PCP, and sometimes that should be a specialist. It really depends upon the comfort of the primary care provider with really serving in that role. But sometimes it's also a particular specialist. I think that there needs to be care management dollars directed to that, because care management belongs at the practice level, not at some centralized health plan someplace. It belongs at the practice level, and it belongs side by side with the primary decision maker for that patient, so that that patient and their family are working with one individual. And yes, sometimes they need to do consultations and referrals and get advice from other specialists, but that person needs to be the primary decision maker. And then that person, I don't think we need new APMs. I think we need to change the MSSP and the ACO REACH program to recognize that, in fact, attribution needs to go to the primary care decision maker, which means that if you're a specialist and you're willing to assume that role, not all specialists are, if you're willing to assume that role, then that's where you're providing the plurality of ambulatory services, you should be the attributed provider. As long as you're willing to play that role and you're willing to be part of an integrated delivery system that's participating in that MSSP or ACO REACH. And that is how we're going to pay specialists. That's how we're going to keep them engaged, because that is actually the most complex work, is to really serve for those complex patients with multiple morbidities and mortality, and multiple comorbidities, is to serve in that function. And that's actually where the savings are. So the money is there. We don't need to come up with a new way of paying for specialists. We need to be able to allow them to be the attributed primary care provider in those programs.
Right. Thank you for that. That's very good information. So I'm going to ask a few scripted questions just to get the conversation started. and then I'm going to ask my PTAC colleagues to chip in and ask some questions. They've been pretty engaged today. So, and the focus of this meeting obviously is integrating primary care and specialty care. And so I'm going to start out with a question that just, what approaches have you used to encourage increased coordination between primary care and specialty providers? And what challenges have you faced, and have you gotten around those challenges? And Art, I'm going to go back to you first.
Yeah, so I think I sort of answered that question as far as my preferred model, which is to put them in the same delivery system and make sure that we have the appropriate person. We also use e-consultation. The challenge with e-consultation is getting adoption, and also there's no payment methodology, but there is within a organization that is assuming global risk. So we use that as well. Within Medical Home Network, we allocate the total cost of care savings as we allocate it to PCPs, but we also allocate it to the health systems. The reality in the inner city and the medically underserved areas is those specialists are employed by the hospitals. And so we set up metrics and make sure that we reserve a certain percentage of savings that are going to specifically underwrite the cost of those specialists. And so in that sense, they are also incentivized through their employers, which are usually the health systems, to reduce total cost of care and improve patient outcomes.
Perfect. Jackson?
Yeah, I think that coordination of care sort of hinges on there being specialists to coordinate with, and so if we're in the behavioral health world, particularly in areas like Texas where there just aren't psychiatrists to coordinate with, we end up doing a great deal of that work internally. I definitely agree with Dr. Jones that when that can be coordinated within one system, that it's much better for patients and cost comes down. I'd be curious to hear more from Dr. Davis, who mentioned a real success with the collaborative care model, because what we found is that once we really tooled our primary care clinicians adequately, that the benefit of having a psychiatrist consultant who was reviewing charts and offering advice just went to about zero. In fact, we just let our psychiatrist go because it wasn't particularly beneficial. It wasn't incrementally valuable after our primary care clinicians had adequate decision support. Now, the linchpin of the collaborative care model being the care manager, that has been really imperative, and more time for the more severe patients, more contacts for the more severe patients. But the psychiatry value has really diminished in the collaborative care model for us.
Thank you. Carol?
Yeah, so what we found is that there's not, most clinicians want to improve care coordination and communication. They really miss it, they want it, they're eager to improve it, but they haven't had a way to do it. So what we've done to implement it is use the medical neighborhood model that I talked about, starting with the referral process, putting something in place with shared expectations, processes, enforcing things like close the loop, but it also required practices looking at their internal processes, because there can be silos within silos in a lot of practices, and there's a lot of chaos and wasted time and effort a lot of times around the referral process, especially if the other processes aren't in place. And I'll give you an example. If there's not a close the loop back from specialty care, primary care spends a lot of time trying to track down the response from the referral appointment. And then they don't have time to send a good referral request, and specialty care has chaotic referrals coming in. So when we can put a process in place on how to do that care coordination, it really helped practices. And this includes all types of practices, including radiology, where they often don't get the clinical question, including work with emergency departments, where there's a lot of referral out. of patients, and hopefully that would reduce if there are more primary cares being fully accountable. So having a structured approach, which includes internal practice processes around the referral, and then making sure to incorporate patient-centered processes and elements within that, because currently most referral processes are schedule-centered. It just amazed me at how poorly patient-centered even the referral out from primary care is, but especially the referral into a lot of specialty care. So I'm not sure if I answered your question, but we found that there needs to be, there's not a scaffolding now. There's not an internal endo structure for how to do care coordination. And so when we provided that, along with measures like how often do you close the loop? What is your wait time? What's your delay in care? I'll say one cardiology practice thought they had a wait time of 3 to 4 weeks, and when they actually looked at the data, it was 3 to 4 months. And at one institution, only 18% of the time did they send a response back to primary care. And in many of the institutions that we worked with, they didn't even have a way to send a referral back if a response back if the referral came from outside of the organization, which most of the referrals did. So I will stop there.
That's a great answer. John?
Sure. Well, let me preface, my answer to your question with a couple of observations. The first is just, a reminder for folks that aren't quite as close to this, but 47% of Medicare Part A and Part B spending accrues to acute hospitalization stays and the 90 days that follow. And the corollary to that is that ambulatory-based primary care physicians largely, are independent of the main clinical decisions that occur during that window of time. So we largely, we tend not to think about, kind of the same simple conceptual model that's, one hub where there's a primary care physician at the center and there's a whole bunch of spokes where the hospital is a cost center. And kind of, I think about it as two hub and spoke models or ecosystems, one that's ambulatory care with a primary care physician and everything that, follows his or her decisions, and then a hospital and hospital-based physician ecosystem, that really, drives what happens around those acute care episodes. As we've tried to drive integration between those two, hub and spoke models or systems, there's two things that we focused on. One is, I mentioned earlier, we have value-oriented, but still fee-for-service contracts with United, Humana, and other payers that directly incentivize both EM docs and hospitalists for the interface between themselves and primary care physicians after the hospitalization episode. And those include warm handoffs, metrics that tie, patient risk status to, being seen by a PCP within 7 days, and use of, IT systems that help close some of the gaps, and help, mitigate the extent to which patients are on the other side of the moon to PCPs when they enter the hospital. And then finally, aside from incentivization around that type of care coordination, I think there's a couple of very practical things that we're incentivized and, paid to do, basically to help patients re-enter sort of the ambulatory care space after the hospitalization episode. And one is we have, universally implemented post-discharge telemedicine service that basically oversees both in-SNF care, but home health certifications, and oversee what happens to patients while they're still getting home health care after hospitalization discharge. In many cases, the hospitals that were managing patients for their acute care illness are much better positioned to manage what happens immediately afterwards, and it creates more seamless handoffs than what historically happens when patients just show up on day one after hospitalization to a PCP's office.
Good, thank you. Nichola?
Sure. Yeah, I think just to echo what others have said, I think one of the key things is communication and how the specialist can communicate back to the primary care provider, and to really create systems that can facilitate that. So for us, a major transition when we went to a unified EMR, and so much of our specialists and primary care communication is within our system. Now, when we have patients that go outside of the system, it really is challenging, and you almost need someone to really do the tracking and get that information back. And sometimes that falls on the provider, and I think we could all agree that that's not a good use of a provider's time, is to track down exactly, what has happened to those referrals and to try to get that information back. So I think things that we could do, to have interoperable electronic medical records would be really key and a step forward in being able to just facilitate that coordination. And I think if I could just answer or address Dr. Griggs's comment around the use of consulting psychiatrists in our collaborative care model, we've still continued to have value with our consulting psychiatrists. They support multiple practices. And one of the things that they're doing, one portion of their work is providing that advice to primary care providers around psychopharmacology and all of that. The other key aspect of their work is actually supervising our social workers. We have early career social workers as opposed to social workers that have been out in the field for a while. And that's been one way of really cutting down on that cost. So having early career social workers who are still relatively in training, as well as our nurses. And so our psychiatrists are really used to support those clinicians as they start to take care of our patients who have varied behavioral health conditions. And our consulting psychiatrists also at times do see those patients who have been more challenging to manage within the collaborative care model and might need more direct care. So I think I will end there.
Perfect. So the next thought is, what have been the most effective payment mechanisms you all might have used to incentivize the primary care and specialty integration, and what and shared savings models or other PMPM models, or what are you using, if anything, or have you found that that's been necessary at all to help facilitate that integration? So I'll go back and start with John.
Sure. Appreciate that. Well, I alluded to, kind of one common model by which we incentivize tighter coordination in our payment models between inpatient physicians and PCPs that resume ownership after hospitalization, and that's in the form of our national contracts with with our main commercial payers. But the second model that we have in place in, many large markets, particularly large markets where there's, very large, well-organized, risk-oriented primary care groups, and I'm thinking of like some of the large groups that, often fall within the Optum family. The model that we have in place with them is one that doesn't go through a payer, but is really an incentivization arrangement that, flows from the primary care groups to the inpatient physician groups, and specifically EM and hospice. So in those arrangements, we get incentive payments that tie to a small number of specific spending metrics that are largely beyond the control of ambulatory PCPs, and those are readmissions, next site of care metrics for the use of post-discharge SNFs, and and total spending on specialty consultations within 30 days of discharge.
Great, thank you. Nichola?
Yeah, so as I mentioned, we do have primary care, we have a Medicare ACO, which is really based within our primary care practice. And our specialists are aware of it, but I wouldn't say that they're fully integrated into that model. Some of the things that are done with shared savings does go into the practice as a whole, though. Which would include the specialists that are a part of that general practice. So they can participate in what we call like the team funds that will go back into the practice for based on those shared savings that come from the ACO, and they can get benefits from that. So I think just having them be aware and be partners in the care and in the outcomes of those patients that are in those models like the ACO has been important.
Perfect. Thank you. Carol.
So I'm not part of a large system, but I can give you some examples. A local independent physicians association in Colorado used incentive bonuses. Now, this is just working on getting primary care and specialty care to communicate better, coordinate better. The first time they did it, they withheld some of the payments that they had earned. They worked with the local payer, and to earn back those payments, they needed to meet certain criteria of like sending a referral with a clinical question, answering the clinical question, that type of thing, just to get started. What Denver Health did is they included metrics around care coordination when they're assessing specialty care. So they actually kept track of how often they closed the loop, how long it took to get that response back, and a few other metrics that they tie in that contribute on top of the specialist RVU salary. So those are at least two incentives that I'm aware of to improve specifically care coordination and communication.
Good. Thank you, Carol. Jackson?
You know, again, probably too early in the journey to speak authoritatively on that. We're banking on the fact that because compared with those who lack mental health conditions, those who do have mental health conditions have higher incidence of hypertension and heart disease, diabetes, asthma, other chronic conditions, and folks with mental health illness are more likely to be hospitalized for medical conditions, and medical spending on those with mental health conditions is some 3 times higher than those without. That this population that we're investing in right now through advanced integration is, as we build out more value-based arrangements, it's going to, particularly because of the high prevalence in our population, be a benefit. But I can't speak authoritatively to how we've captured those dollars and reinvested it to further incentivize the project.
Good. Thank you. And then Art?
Yeah, so one of the problems we face, again, with the Medicaid population, not to mention the uninsured population, is a lack of specialists willing to serve that population. So things that we have that we're rolling out this year, so we're just about to roll it out, is to actually give salary support and pay a specialist for half a day a week and cover a slot half a day a week, in which we're going to give them salary support. And during that half a day, they will do 2 things. One is that they will respond to e-consults. And secondly, they will actually be scheduled to have phone consultations with primary care providers to really cut down the wait times. And the appeal to the specialists is that they get frustrated because they realize there's not enough of their colleagues willing to serve that population. So the more that they can do to actually improve the ability of the primary care providers to serve those particular and meet those needs. And a lot of that happens because, unlike usual consultations where there's one note, there's not an ongoing back and forth conversation. With e-consult, you can do that even better with phone consultations. So we're going to roll out this year is paying them for salary blocks to cover their cost to provide that type of service. We'll see how it works, but that's our plan for this year.
Great. Thank you for that. And we have a question from one of our PTAC members, Jim Walton. Jim?
Yeah, thank you. It's kind of for Jackson and Art. Thank you both for all of you for being here, and particularly Art and Jackson I've worked with in the past. I want to kind of, it really, my question kind of ties into kind of what Art just answered a little bit, and I want to kind of bring it back. One of the things that PTAC, that I've learned being on the committee, is interested in is the idea of health equity, the ideas of health equity, and also the space of rural, semi-rural, underserved areas. And Jackson, I think what I know about what you've done and what you've explained today is that you solved for a problem because of lack of fill-in-the-blank behavioral health support, to the point where you've got a working model. And I would argue maybe what Carol was talking about and ACP's been talking about, which is this medical neighborhood, you actually have it next door or in the same building, right? It's co-located. But I also am, aware of the financial realities of FQHCs and other rural doctors. When I was practicing in Waxahachie, the same kind of, if I was still there, if I was trying to put together a medical neighborhood of specialists, I would be challenged economically with how to do that. Let's just say if I wanted to care coordinate complex patients that have low income and low health literacy, and they've been marginalized on and on, with complex problems, how could we actually break through that, right? And I hear that CMMI and PTAC are very interested, like laser focused on that question, right? And so that's why it's so important that y'all are both here today, to talk about that, right, in my view, because we have this historical burden of generations of issues around these populations that are experiencing today and tomorrow. They will continue to experience inequity in both access and care delivery and outcomes. And so what would you say, right? What if you said, hey, if you could give the ACO that I'm contracting with X, I will create a medical neighborhood around Y to complement what I've already built, Z, because you built it with your own money. And I think what I heard Art saying is, hey, we're going to now we've got an idea where we're going to pay half day for e-consult and phone consultation with PCPs. He's in effect a virtual medical neighborhood builder, but he's using funds from somewhere, right? And so, but those funds are not necessarily easy to get access to, and Art can speak to how he got access to those dollars in his contracting mechanism. But I'm a little bit more familiar with Jackson's world, coming from Texas. And so I'm just curious, Jackson, if you would go first, and then Art, maybe you would comment on him. What could you advise us, to say to PTAC, say like, what could we actually recommend ACOs that are on a total cost of care, professional cap, what could they do to help you build out what you need for your patients to create more equity? And where would you start after BH and, the lessons that you've learned with BH?
So multi-part question, Jim. So if I don't get to answer all the pieces of it, feel free to just ask me again. But we as I sort of demonstrated with payer mix, we live on a really a knife's edge financially, and it's really exciting to hear about the larger groups of FQHCs that have been able to kind of solve for this. We can tolerate some in bigger systems. Upside risk seems to be like no risk. It really is for us if we make some investments in an initiative using time and resources, and then there is no positive ROI. Then that has real meaning to us. I mean, I think that there's more anxiety, of course, around downside, but for us, even the upside is anxiety provoking. So the notion of either an ACO or health plan investing on the front end in the initiative and bearing the risk, if in other words, if, for example, we need additional care management staff or care coordination or fill in the blank that's not borne by the FQHC, the investment. Now, if the contract were such that as positive ROI occurred, some of that investment gets paid back almost in the form of essentially a loan, but it gets paid back whenever either shared savings are achieved or whatever. Then that seems like a viable way. Win for us because we have new services for our patients. Win for the health plan or the ACO because they're getting better quality. But if there isn't a positive ROI, then we're still not holding the investment, even again in the upside only. So that would be one way of making an arrangement such that that those of us who are just so constantly conscientious about every dollar because we're always a hair's breadth away from deficit, would work. Now, from the standpoint of equity, I think that what we have seen in mental health is, and I think this is corroborated by the literature, it's that different subpopulations for very clear historical reasons have less trust in various aspects of the healthcare ecosystem. So while trust in primary care might be relatively high, trust in mental health services might be lower. So by virtue of saying, hey, this is a part of the basket of services that we provide in primary care, when you come through our door, we're going to offer you behavioral health services as an aspect of primary care, then the disparity between the access disparity, really goes to zero, because the populations who tend to be more reluctant to see a psychologist is now seeing a mental health specialist in the primary care arena. Similarly, I just think that there's such value in co-location. Next door, let me introduce you to the cardiologist who's here today. Bringing so in those instances where that's feasible, that's outstanding. But if you're in Waxahachie or in Muleshoe, Texas, then potentially the primary care site being the place where you leverage the trust with primary care and invite that person to see the rheumatologist on in the telehealth platform, just right next door. Hey, let me usher you into this room. I'm going to introduce you to the rheumatologist or the rheumatology nurse, and she's going to introduce you. This is somebody I trust. I think that could also similarly decrease the disparities in access.
So I would. So first of all, we're fortunate enough. The Illinois Medicaid Agency put out some grant opportunities that they wanted to see practice transformations. So the program I'm talking about is being funded for a 3-year trial because it takes time to build it up and demonstrate impact. This is being funded by the state. And that is in distinction, to example, to what CMS has done with the advanced payment under MSSP for safety net providers. Because what they're not doing is they're not asking for us to pay it back out of our shared savings. In fact, MSSP, if you're going to make it, one of the changes I'd really recommend you make is that if you borrow that, say, $250,000 for your MSSP, when you pay it back, you're paying it back on your portion of the savings, which is not fair. I mean, so if in fact I use that dollar to invest in care management, that should count as a cost, just like a medical cost, and be shared by CMS as well as the providers. Why should all that portion come out of my portion of the savings? So that's one issue. The second thing that's for federally qualified health centers and for rural health clinics is something called change in scope. And so to the extent that you decide that, hey, what I want to do is I want to move towards adding specialists to my staff, you can appeal to the state. There's a mechanism to pay the additional cost. It impacts your encounter rate. So that's a second methodology. A third methodology that we're moving towards is moving away from the fee-for-service chassis for reimbursing FQHC. So we've moved to primary care cap. There's also in BIPA an option that says you can move away from fee-for-service and move to an alternative payment model. So at Medical Home Network, we've been in primary care cap. There was nothing like primary care cap during the pandemic, but we were already moving in that direction. It's something, as I think you probably realize, we did back in 2001 at our health center. And what that does is it gives us the flexibility to say, how are we going to allocate our resources? How are we going to best use the full care team and not worry not whether it turns into a billable visit? When I'm work now in 9 different states under HMA with FQHCs and their primary care associations to develop a primary care cap alternative payment model, I can tell you it takes about 3 years. There's no reason for that. There's no reason so that we can't streamline that process, that CMS can't come up and sort of say, well, if an FQHCs choose to move from fee-for-service PPS to a capitated APM, here is a strong model. You can certainly flex it. Then what that allows me to do, see, the nice thing about ACO REACH is I can pay primary care cap. The bad thing about ACO REACH is that for FQHCs, Medicare is usually 10% of their population. I've got to put in models of care that work under capitation for my Medicaid and for my Medicare. And quite frankly, they work very well for my uninsured because I lose money every time I do a face-to-face visit with an uninsured anyway. So I think another recommendation to you is to go back and say, can we streamline and make a uniform approach to primary care capitation, which basically takes the historical revenue that an FQHC got for their primary care services and turns it into a prospective PMPM. And then the last thing you're seeing is that traditionally what's happened is the RAP payment, which is the difference between that PPS rate and what the MCO pays for the private doc down the street. There's an increment that's why they get PPS. It's to reflect the fact that they are required to provide additional services beyond what a primary care practice has done. What has happened increasingly over the last few years is that states have decided they're going to put that RAP inside the premium and make the MCOs pay it, which in effect, what that does is it takes that RAP in terms of shared savings and shared risk and distributes those funds across all providers, not just FQHCs. So just think about it. If my PPS rate is twice what the Medicaid reimbursement rate is, and I have a shared savings on a percentage of premium basis, and every time I do a primary care visit, my shared savings pool gets drained twice that of the guy down the street, it puts me at a severe disadvantage in terms of performing. So I think there's some really concrete things that we can do, particularly around the safety net, to really get them moving. FQHCs are lagging behind in terms of value-based payment in the pursuit. And there are things that can be done, very concrete things that can be done to get them and make it feasible for them to get involved and really be chasing value-based payment arrangements.
Anybody else have any other comments? If not, I'm going to open it up to the other PTAC members, and Larry has his hand up. So, Larry, you want to go?
Thanks for the presentations, everybody, and nice to see you again, Carol. My question is going to go both to Dr. Jones and Dr. Greenlee. I'm intrigued about your concept of providing, I would imagine, a PMPM payment to a specialist when they become the principal care provider and they're assuming care. I'd love to tie this in with Dr. Greenlee, and I want to understand this transition. So a primary care doctor calls a specialist in for a certain service depending on an illness that now, let's call it diverticulitis. A patient goes into it, they have multiple medical problems, but they go to an episode of diverticulitis, which requires that gastroenterologist to take over care. How does the payment work there? And then the transitions, and this is where Dr. Greenlee would come in. How do we transition these back and forth? How does it come back? Because we know very clearly that these things bounce back and forth between doctors for a period of time.
Who would you like to respond first?
Either one. I don't care.
Well, I'll respond that I think that the specialist that is willing to be the primary decision maker is someone who is managing chronic conditions. So it's obviously not a surgeon. I would even suggest it's probably not necessarily a GI person with someone with acute diverticulitis. I think it is it's these patients that have multiple chronic conditions where they're willing to say, I'm going to be the primary care decision maker. So it's your patients with advanced CHF, your oncology patient, your end-stage renal patients, it might be your COPD, and they're sort of saying, well, I realize that this person has CHF, but I'm also realizing that he has diabetes, and so I'm going to still be the primary care decision maker, and I may at times say I'm going to use an endocrinologist to consult with me, but I'm going to serve that primary care role. And they have to be willing to do that. And they can't act as traffic cops. And that's what's happening too much in medicine today, is that people with multiple conditions go to the PCP, and the PCP feels overwhelmed, so they just start sending out multiple referrals. And the specialists don't talk to each other because they're not paid to talk to each other. They're paid for certain services. So we need somebody who is going to be. So if that specialist is willing to play that role for those complex patients, then I think they should be paid a PMPM for that role. And I think they should they'll get paid for their fee-for-service system, but their real incentive is just like any other PCP group, those people are attributed to me to the extent that I reduce their risk-adjusted total cost of care, that I'm going to get a portion of that savings.
I can say when we were working on all the different stages of the patient-centered medical home neighbor, that in the beginning, every specialist wanted to be a medical home, mainly because they thought they were going to get more money that way. But when they realized what advanced primary care is, we look at primary care as a specialist in primary care. And then the other specialists are a specialist in GI or even, neurology, but even within neurology, there's subspecialists, or within endocrinology, there are people who only do adrenal, et cetera. And most of even the nephrologists that worked on our work group do not want to take on primary care. What they want is better coordination with primary care. But when a patient has a consuming illness, which were most of the conditions that Dr. Jones just mentioned, at that time, specialty care may need to be the team lead. They may need to be the one that organizes the other referrals. They may use the patient's pre-existing specialty care, like an endocrinologist. They may use the primary care, but they're the main organizer around that critical illness. They take first call if the patient has pain, bleeding, fever, whatever. But if that condition either goes to end of life and transitions back to primary care, or gets better, like with the liver transplant or something, there does need to be a transition back. And there needs to be defined expectations around what is required for that. And I think that's what you're asking, Larry. How does that happen? There needs to be agreement with the patient, the specialty care, and primary care about transitioning back, so no one's left feeling frightened or unattended. Specialty care needs to send the care plan for what's needed and other documents like what happened during this time, so that primary care has that. The patient needs to have a copy of the care plan, what needs to be followed, what needs to be done, and specialty care needs to be available to help primary care if they have questions after that transition back. And the patient needs to know that there's a safe route back to specialty care if they need it, if things get bad again. Larry, I don't know if I answered what you were asking.
No, I think you both did a good job there. It's the serious chronic longitudinal illness that may be best managed by a specialist, and that has to be clearly documented and communicated for the care team. And then somebody who's paying the bills has to be informed of that as well, so that payment is going to the appropriate provider.
I think John has his hand up too. I think you're on mute.
I just wanted to add one sort of additional observation in thinking about how to share risk between primary care physicians and specialists. And I agree with Art that if you're thinking of it through the lens of specialty, of specialists, sort of medical homes, then I think the paradigm of co-management of chronic illness by rheumatologists, endocrinologists, ambulatory cardiologists, well, that model makes sense. And But on the other hand, before you exclude other types of specialists, and let's say interventional cardiologists and cardiovascular surgeons, while recognizing that those groups never really take longitudinal management of those patients, they make a small but real number of decisions about like really expensive things that just have a disproportionate impact on total spending and on variation in spending. So the medical home model isn't exactly right, but there certainly are models by which those types of groups could be held accountable upside and downside to not just quality, but to total spending, for that population of patients, for that portfolio of like high impact, high cost things.
Thank you. The question I have is, are any of you using non-physician resources, teams to help facilitate communication and integration from primary care to specialty care? And are you accessing chronic care management billing to support any of that? I guess I'll start out with Nichola.
Sure. So yes, we use non-physician team members. We have nurse care managers, for example, that will help with care coordination. For our collaborative care model, we're using nurses often in that model, as well as clinical social workers, and we're billing within the collaborative care model. And so we are able to do some billing for that care coordination. We use a lot of, we're fortunate to have a lot of community health workers, and that's been funding that's come from the cities. And these, they do lots of non-billable work right now. We hope that there will be some movement in terms of reimbursement of the work that community health workers do. And they really help to help patients to kind of navigate the system, make sure they're keeping all of those multiple appointments that might be between the primary care or the specialist, help the patient to kind of communicate with providers and ask the right questions. And so really help them to be advocates of their own care, and so that they can help to kind of bridge some of that gap as well as really importantly helping to address our patients' social needs. So, and I think the other thing I would just say about this conversation is we have to really be thoughtful as to what the patient really needs and what those patient outcomes are, because I think we often will live in those silos of thinking about, the specialist care outcome and the primary care outcome, and thinking about this in terms of cost, but we really also have to think about all of those patient-related outcomes and what's important to the patient as they're navigating the system and going from primary care to specialist and inpatient to outpatient. It can really be traumatizing for the patient, and really giving them the support so that they can manage all of these different providers and provider groups that they're in contact with is really important too.
I'm so glad you said that, Dr. Davis, because I was thinking the same thing. I mean, it's so easy just to fall back into that physician-centric way of thinking, and people become cogs in a very complex machine. And we've got to be asking the patients, do you understand what matters to you? What are your goals? What do you, as opposed to just assuming that, this organ's broken, so this management needs to happen.
I would just like to add that, yes, the medical neighborhood I talked about is outpatient ambulatory, but it certainly needs to interface with whoever's in the hospital. But what we built into that made it more patient-centered. So we suggest that the primary care clinician, when they're going to refer the patient, talks to the patient about it. You'd be amazed how many times right now a patient is referred and they don't even know they've been referred. Specialty care gets a referral and they're cold calling the patient. But we don't want that to happen. We want the patient's goals for the referral to be clear and give them information about where they're being referred, how to get there, what the role the specialty care is supposed to play or what primary care has asked them to just give advice. And if primary care can get it through an e-consult, truly support that. But if the patient needs to be examined, say we're just asking for advice, or I want them to help manage, and then to be also very clear, once you're stable, I'm going to take this condition back over. And again, it's for the condition, not for the patient. Or I want, this is panhypopituitarism with diabetes insipidus. You'll probably have the endocrinologist manage that for a long time. But make the patient be part of it. And that's part of that pre-visit review too. Which patients are more urgent? Which patients really don't need to take the time to come in? Which patient needs to really go to urology instead of nephrology? All of that is much more patient-centered. But building that patient-centeredness into the referral process and then the ongoing care as well. Thank you all for mentioning.
Yeah, I would just mention that Medical Home Network takes a portion of our savings and passes down to the medical homes to hire community health workers to do the collaborative care model, not just for depression, but also for hypertension and diabetes. And we use the COMPASS model for the collaborative care model for depression, which basically was one of the CMMI Innovation Challenge grants that showed that using a trained community health worker in the collaborative care model for depression was just as effective in terms of patient satisfaction, provider satisfaction, and PHQ-9 improvement as it was using behavioral health clinicians. We do not have enough behavioral health clinicians to serve our population, so everything's kind of moved down the slots. So we end up having them be the contacts. It's clinically licensed social workers and clinical psychologists at the FQHCs that go over the cases, and we use e-consult to go to the psychiatrist when we need help in terms of medication management. And so it's really kind of saying, hey, again, that's the care team approach. How do we best utilize, because there are not enough primary care providers and behavioral health providers to serve the underserved.
John, any thoughts?
No, I don't really have anything to add. Thank you.
Yeah. All right. We're getting close to time, but I am going to ask one last question, and maybe we can just make this brief, but just a question around your access to data and how difficult an issue is that and where you're getting your present data sets for, particularly in regards to things like risk stratification and specialty referral decisions, et cetera. So I'll start with John.
So again, I'm speaking through the lens of care models that are based, during and around the acute hospitalization stay. But our data, come from three sources. One is we get real-time and continuous feeds from our hospital partners with regards to who the patient is, where they come from, and what clinical diagnoses they're actively managing. We have our own IT platform that basically not only manages physician billing, but basically runs through value-based care checklists, which includes social determinants of health to the extent that they drive, some of our key metrics. And then finally, with a lag, we get payer claims, particularly from both governmental and non-governmental payers with which we have risk-based arrangements. Those, kind of the data that we have serve our fairly narrow purposes, but, what's really missing is any connection between sort of that, acute care data flows and, what's occurring on the ambulatory setting, both prior to and after, acute episodes.
Great, thank you. So maybe in contrast, Carol.
Well, when I worked with practices around the country, it was really hard to get any data on specialty care. If you wanted to see what their unnecessary preventable ED and hospitalizations were, it was really, really hard to get that. You had to try to sort through ADT data to see which applied to the specialist. So we ended up doing patient surveys to see how often the patients felt they couldn't get in to see the specialty care when their condition exacerbated, if specialty was the principal co-manager in that situation. I know for our primary care clinicians locally, one of the payers gave them just the spend for specialists, but it's not divided down for how complex the cases were, but they knew which specialists spent more money. And that was the limitation of what they knew when they were going to select who to refer to when they were in a capitated Medicaid program to try to save money for their program. So we need more data. I'll just say it's really hard to get it for specialty care.
Anybody else want to comment?
Yes, the Medical Home Network gets complete claims data from our payer, including pricing. We get medical claims on a weekly basis. We get daily pharmacy claims data in addition to the ADT feeds. We also have an 84% collection HRA completion rate that includes social determinants of health. And we're using an AI vendor that on a dynamically risk stratifies our patients. We high-risk care manage 3.2% of our population, and that AI vendor puts in all the data and comes up with risk stratification that's specific to our 178,000 Medicaid beneficiaries. It tells us who's going to most likely be benefited from high-risk care management.
And I'll just add, we use a lot of our clinical data is the bulk of what we have, and it does have both our acute inpatient episodes as well as our outpatient episodes, and as well as our specialty visits. And we have risk stratified our population internally, looking at various variables to be able to estimate who's more likely to have a future hospitalization. And so that's really been helpful data that we can use to then think about how we proactively outreach and address that patient population. We also incorporate some of the data that might reflect their social needs, like whether or not they're a patient who's experiencing homelessness. That can all go into how we stratify and look at our patients who are high risk. We also look at our scheduling data. So we have access data for all of our clinics, both our ambulatory care as well as our specialty clinics, to see how long out the wait is in terms of just availability for those practices. One of the challenges, what we don't necessarily have, or it takes a long time to get into our system, is external utilization. And so that's challenging to know when patients are getting admitted outside of our system, and it might take a long time for us to get that information into our system. But we do have lots of data that we're able to use to proactively manage the patients that are receiving care within our system.
Okay, thank you. So we've only got a minute left. I see Walter has a quick question. So.
Yes, hopefully this will be very quick. I just wanted to thank all the panelists for being here. And this is a question for Dr. Birkmeyer. John, it's nice to see you again. The current specialty payment framework that CMMI put out last fall contemplates paying specialists in part for acute care episodes in bundled payment nested within a more total cost of care, total accountability model. And I know Sound has a lot of experience with bundled payments. I'm just wondering if you could comment on the kind of interactions you've had with BPCI in the setting of total cost of care models like ACOs or other kind of total risk frameworks.
Thank you, Walter, and good to see you again. Sound does have a huge experience in managing to episode-based alternate payment models, and we've run about 300,000 or 400,000 acute hospitalizations through those programs, and really kind of the core measure of success, both for patients, their families, but also for managing total cost of care, is primarily around managing post-acute care in admissions. And I think that that's like very much sort of the sweet spot of, hospitalists, which are basically the PCPs of the inpatient setting. I disagree with CMMI's focus, last year when they were, trying to solicit input on the role of other types of specialists. I think that there is some role that other types of specialists play with regards to managing the acute hospitalization. But I think certainly epidemiologically and from a spending point of view, their biggest impact is not in how efficiently those episodes get delivered, but in how many episodes there are. So their decisions about who needs surgery, who doesn't need surgery, who needs to be hospitalized, who doesn't, that's really kind of where the focus should be. And that's not an episode payment model. That is a population payment model.
I agree. Thank you. Well, we've unfortunately run out of time, but this has been a great discussion. And again, we want to thank all of the panelists here for being willing to participate in this discussion. You've given us lots of information to chew on. And again, just to appreciate your participation. So thank you.
Thank you, everybody.
Okay.
Produced by the U.S. Department of Health and Human Services.